Hi everyone, my name is Rachel Moses and I'm a consultant respiratory physiotherapist and I'm working in a Chief Allied Health Professional role at the moment, and I'm delighted today to be joined by three incredible women who are going to talk about sex, sexual health, continence and all things that matters. And I'm just going to start by introducing people around the table. So on my top left I have Kate, who most of you will know as a senior sister in ICU rehabilitation and the original hashtag rehab legend. We have Elaine on the bottom left of the screen, who is a pelvic health physiotherapist, self-proclaimed fanny physio, but she doesn't discriminate, everything else in between for both genders. And she is also a comedienne extraordinaire. And last but not least, we have Liz in the bottom right-hand corner, who is a retired consultant breast surgeon, having previously had breast cancer herself, and so has been through that whole process and speaks from the heart with regards to that. And she has a very keen interest in sexual health and intimacy and has got some incredible podcasts, which I'm sure we'll link into this. So thanks everyone for joining us today. So I'm going to start by being a little bit brave and saying, as an ICU clinician, as a respiratory consultant, we don't talk about sex, we don't talk about intimacy, we don't talk about masturbation, we don't talk about sexual health, and we don't talk about continence. And not just during COVID-19 pandemic, but for anyone that has survived severe critical illness, there is going to be an impact on your behaviours, your personal behaviours, and we just don't look at this. We just don't address this. We don't ask the questions either in the acute phase or when people are discharged or in clinic. So Kate, I know we have a massive shared passion in this. So can you just talk me through how someone coming into intensive care might, develop problems, issues, anxieties?
So post-intensive care syndrome is kind of the syndrome of things that happens to patients after intensive care, and they're in three main groups for patients and one for families. And I think they're all really, really, really important when we're talking about intimacy and regaining intimacy after intensive care. So there's the kind of physical components, which we know from our COVID experiences we know it's going to include fatigue, but normal ICU patients after ICU, so non-COVID patients after ICU, are going to be highly fatigued. They're going to have muscle loss, muscle weakness. They might have new scars. They might be, not have had anyone touch them anywhere but in a kind of clinical sense in a very long time. You've then got your kind of potential cognitive impairment after intensive care. You've also got psychological impairments after intensive care, like anxiety and depression and delirium and post-traumatic stress. All of these things are going to affect sleep, are going to affect how you're feeling about yourself. And I think confidence is a key thing when you're starting to kind of restart an intimate relationship with a loved one after intensive care. And then in loved ones, we see anxiety and depression and post-traumatic stress as well. So after intensive care, a patient, my favorite patient quote is that being in intensive care is like throwing a hand grenade into my life. Everything was blown apart. I lost everything. I lost my role as a mother, a daughter, a pet owner, and as a partner. And I think I think the medical model of intensive care for a long time has, you've survived intensive care, you've done really well done, you're alive, you're so lucky. And we forget that we have to rebuild every single area of somebody's health and love and well-being and future after intensive care. And I think sex and continence isn't something that we talk about, and intimacy isn't something that we talk about. So we talk about it a bit in our follow-up clinics, but I think it's something that we have to kind of get clinicians and ourselves much more comfortable with talking to patients about, because actually they need us to help rebuild this area of their life with them.
Absolutely. And I think you've touched on survivorship there. Now that is quite a powerful thing, isn't it? You've survived. You should be so grateful we saved your life. And we talk about we talk about what happens post-recovery in terms of, you mentioned surgery. Is the surgery okay? Has it been successful? Are all your internal organs functioning how they should? But actually it's so much more than that. And I want to bring in Liz now at this point, because you have very personal experiences of this, but also huge professional experience.
As a consultant breast surgeon, before I was diagnosed, I don't think I ever talked about sex with my patients. You run through the symptoms of the menopause that the treatments can give you, but that was it. I wasn't interested. I didn't realise how much of a problem it was. And when I was diagnosed at 40, I had chemo, I had surgery, I was thrown into an instant surgical menopause overnight. My libido disappeared, my body image disappeared, I got a scar on my chest. It affected my marriage. And I've spoken to a lot of women online, and every single woman has said at some point they wanted their husbands to divorce them and go and find a healthy woman with 2 boobs and a libido. Because I never wanted sex again, I just want a cup of tea. And when you're in a healthy, loving relationship, you have to come to terms with your own scars. And I had chemo first, and my husband and I were trying to be intimate. And you think, does he touch my bald head? Does he touch the cancer in my breast that he can feel? What do you do about this? There is so much. And when I went back between my first diagnosis and my recurrence, I thought, right, I'm going to talk to patients about sex. And it was at the 1-year follow-up. And there were often couples in the room, and I said, you're going to find this embarrassing, and I'm going to find it embarrassing, but I don't care. There are things we can do to help you. Because I had to learn the hard way about vaginal lubricants and pessaries and dilators and things you can do. And no one talks about it. And I wrote a blog, and I've had women crying, saying, thank you, I'm not alone. There is something I can do to start being intimate again. I had no idea how unhelpful I was being to my patients.
I mean, even that is so powerful, isn't it? So in terms of we have very little data here from the intensive care world. We have some data from the respiratory world in terms of continence and sex and breathlessness and positioning and pacing. And I think it's kind of easier to do. We have great information from the British Lung Foundation, for example. Some of the societies like the MS Trust have great sexual health advice, but one of your things, and one of all 3 of your things actually, is about intimacy, isn't it? It's not just about the kind of the act of having sex. So Elaine, can I come to you now for a second, please? Because you very much have a strong opinion on this, and in your own words describe kind of how we can help and support patients and what they should be mindful of.
I think the basis of the problem is that as clinicians, we're not educated on how to address these problems with patients. So you land up with a situation where somebody might have an insight into that this is a problem for the patient, but you're standing behind a curtain with other people around. So it's not appropriate to start asking deeply intimate questions of that person. And then if they divulge stuff to you, what are you going to do with that information? You don't know where to refer them to. You don't know what to say in order to help. And because sex is such a taboo, everybody has their own biases and their own hang-ups about it. And there's a huge sort of ageism issue as well, that, you know, with menopause, well, you're not going to get pregnant now, so why should you be bothered about having sex? It's not a thing that's addressed. There's no vehicle to educate women about their sexuality. There's very little research into female sexuality. There's no pink pill. They did try to make one, but it was an absolute disaster, and they trialled it on men. So go figure that. In order to address these issues with patients, we first of all have to support the staff and give them basic information about what you can reasonably expect from your genitals during the course of your lifetime, and address what that flags up for the clinician personally, so that then they're able to direct patients to somewhere that's useful. And unfortunately at the moment we don't really have great sexual health services in the UK. Everything's grossly underfunded. Basic sex ed education is poor, and it stops at 17. You know, so if we had a system where we were able to teach people, you're an adult, you're entitled to have a sexual relationship, whether that's something that you're doing on your own or with a partner or a series of partners, it's part of being an adult. So that's something that we need to look at. Like, I would like to see a central website so that clinicians can just click into it and get what evidence-based information that there is, and this is how to bring it up with your patients. And then conversely, for people to be able to have the information to articulate to their GP or whoever it is that they're speaking to, I need help with this. Because, you know, I work in pelvic health, so I'm just see genitals all day in clinic, and the level of ignorance amongst women about their own bodies is really, really, it's upsetting, because there's lots of women that I see that have had a number of children and they don't understand that they've got 3 holes. We don't teach, in sex ed, we teach young women about periods, but we teach young boys about erections and sexual function. So often it's really complex because people don't understand what is normal. and therefore they just know that everything feels weird and different, and it's not going well, and it's really unsettling.
So if COVID has taught us anything in healthcare and anything in acute medicine and in intensive care medicine, is that now is the time for change. So we appreciate that not everyone that comes into intensive care might be sexually active, like you said, either with themselves or either with someone else. So this isn't a kind of one model fits all, and you can't just be asking people who survived, you know, significant critical illness at that moment in time in the intensive care, you know, just before they go home, you know, do you want to be able to masturbate again? So how can we start this in the acute phase? What simple things do you think can we do that will make a massive impact down the line without having specific services we can refer people into?
I'd use the catheter as the in to having the conversation, because everybody that's in intensive care is going to have a catheter, and that is going to cause irritation in your urethra. So that gives you an automatic entry level conversation to have with every single patient, that this is going to affect, you might not have good bladder control because it's irritated, you might be getting urinary tract infections, and your sexual function might be affected by this.
Kate, I'm going to come to you because I absolutely love even that thought. What do you think?
I agree. I think the catheter is a great way in. I like a good way in that I kind of raise with patients is I talk to them about how are things are you. So often people have slept in different bedrooms when they first get home because their partner is scared about hurting them, or they have specific pillows in specific areas. So often I get in with how are you sleeping, and then I kind of lead it in from how are you sleeping, and are you sharing a bed, and then kind of use that as a way in. But I think intimacy is a really good way of exploring what the patient's previous normal was, and then helping them down to get back to wherever they want to get to. So for a lot of my female patients, they kind of worry that it's a service they have to offer their husband as though it's a marriage breaker. And I think it's about trying to get them to reframe that they've got to be right, they've got to feel comfortable with it in their own head before they can start regaining that relationship, and all the things they can do. And we can talk about their mental health, about supporting their mental health and potentially getting some interventions if they need it. But there's lots of, so, you know, we talked earlier about there's lots of stuff you can do that isn't just penetration, about restarting the kind of massage, the touching, the, you know, feeling comfortable with each other. Because I think if you've been in hospital for a very long time, you're not used to anyone touching you. You're just not. So loads of my patients just aren't used to anyone touching them at all, like even holding their hand. So I will often start with, have you thought about any massage? And massage can be a really good, nice way in to kind of help with muscle strength loss, muscle weakness, body dysmorphia, you know, all that kind of body changes stuff. So, but I think it's really important that we just start having the conversation and talk about and kind of leave some of our fears at the door. I'll always start with just, okay, how are you and how are things? And often it can just lead gently and naturally there. I think we have to not feel worried. And if you don't know the answer as a clinician, that's okay. And if they want advice, I'm sure there's lots of great advice out there. I think we're worried that if you don't know every single sexual practice in the Kama Sutra, can you give her advice? You can, you just need to not worry about it, I think.
Thanks, Kate. So I'm going to come over to Liz now. So I have the most amazing respect for my ICU consultants, and they save lives. They're incredible clinicians. But again, I'm probably going to be a bit brave and say I don't think any work in the acute phase or in the post-acute phase where they would openly feel confident to ask about intimacy, sexual health, sexual practice. What advice do you have as a clinician who's been there and changed their practice for my colleagues? Where do people even start?
I think it's really, really hard. It's not a normal thing to talk about it. Very few of us actually talk about sex with our partners, let alone our GPs or a doctor. And there's one thing doing it in a clinic, there's one thing doing it behind the magic blue soundproof curtains. I would say to get every single healthcare professional looking after a patient to say, it is normal for people who've had this procedure to have problems with intimacy and sex. And when you're ready to talk about it, there are things we can do to help and guide them. You may not be the person, you may hate talking about sex yourself. So you don't want every person to think, oh my God, I'm the guru. But if you could say it's normal to feel like this, and if and when you're ready to discuss it, there are things that can help. There's a leaflet here on the breast cancer care website. You could see your GP. You and your partner may be able to get counselling. I didn't realise my own hospital had a sexual health counsellor for cancer patients until I went back to talk there 3 years later. I didn't know they existed. But I think if patients know it's normal, and it may not go back to normal, but there are things they can do to help, that just relieves that worry, and it makes them think, okay, it will be different. And then it's having access to resources you can send patients to, because I wouldn't know where to look before I had breast cancer. I wouldn't know what to say.
Yeah, I think that's the thing. I love that sentence. It's normal to feel like this, and I might not be able to help you, but I will find someone that can, and ingraining it in the rehab pathway now.
Because they may not want to talk to you. You may not be the person they want to talk about their sex life or their dry vagina with. They need to find someone they feel comfortable to share. And it may be they want to do it with their partner or without their partner. And it's really hard. But again, just telling them there is help out there and knowing where to send them.
Yeah, and I think just be playing devil's advocate here. And I actually had a conversation with one consultant once who did do post-ICU follow-up, and they said, what's the point? I'm not going to ask about that, because what's the point? So, and it's, I suppose, to be a little bit controversial here, why should we ask? Why should we signpost? What is the point?
I think as a consultant, before I had cancer, I judged my career on how pretty my scars looked, and did patients come back with complications. That was what I thought was a good result. And every conference you go to, it is all about, look at the pretty scars, look at my mortality figures, my patients don't die. But you suddenly realize that the day the consultant says goodbye, see you in a year, is the hardest part, because you have to go back to living. And there is no point giving them an excellent service, whether that's in a cancer clinic or an ITU, if that patient goes back and they've lost their self-esteem, their job, their marriage. There's no point treating them if we're not going to get them back to a decent quality of life. And you don't get that unless you talk to patients. And that's the problem. Most doctors and nurses and healthcare professionals never have the time, or they don't actually care to hear what it's like to live with the side effects of the treatment, because they're so busy moving on to the next patient. And I think you need to learn from young women who've had stomas on ITU, who have painful sex and cry, and actually, I need you to help me because this is important. And it's how you get that patient message across and make doctors and nurses hear it and understand it.
You've said a couple of really powerful things in that I'm going to come back to, and certainly in terms of some neuromuscular patients who have had terrible neuromuscular admissions into intensive care, and that paid for sex bit is really important, because some people want to have sex with themselves or other people and they physically can't, and the stigma around that, but I will come back to that. Elaine, I want to bring you in at this point, please, because the so what factor. So we're not going to ask about sexual health, because what does it matter? It's someone they've survived critical illness. Can you tell us some of the more wider economic kind of impacts on a person, on a community, on a family, of us having, not addressed these issues?
Yeah, there's a lot of data in pelvic health about this stuff. So it was mentioned earlier on about being sort of grateful to have survived. And so there's data from women that have had 3rd and 4th degree tears after vaginal birth. And their attitude is, well, I should be grateful because I've got a live baby. But the impact of that tear in their quality of life is immense. There isn't anything that impacts on your life more than being fecally incontinent. It interferes with absolutely everything that you want to do and everything that you think about yourself. Anything that takes away your dignity is devastating once you're out of the hospital. People are quite happy to be completely vulnerable, and they're not happy about it, but they accept in hospital you are vulnerable. But once you leave the hospital and you've still got all of these problems, it's absolutely humiliating for people. It takes an average of 7 years for a woman with stress incontinence to seek help. So when she's laughing, coughing, crying, exercising, and she's wetting herself, she doesn't tell anybody about it for an average of 7 years. So it's not uncommon for me in clinic to find women who have been leaking since the baby was born, and the baby's in their 20s, and they've just been tolerating it because of shame and stigma and myths that this is just to be expected, it's part of getting older, it's part of being a parent, and these things aren't true. There's lots and lots of myths that surround surviving critical illness or having an accident that is life-changing, and this sort of idea about survivorship, that should be enough, is a real medical model, and it's not how people operate. When you look at the markers for quality of life, incontinence in older people is the biggest indicator of how well they are functioning. The second most common reason for a woman moving into residential care is bladder and bowel control. So these things are hugely important to everybody in their everyday life, because how can you work if you don't have good bowel and bladder control? How can you have intimate family relationships if your sensation has changed or your body image is such, like, even things like people that have lost weight after being critically ill, through muscle atrophy. The shape of your pelvis changes because bits that were padded before are no longer padded, and that has a practical element for somebody trying to resume an intimate relationship. That simple advice about how to pad up your bony sacrum with using a towel or a pillow, these are practical things that physios are very good at doing. We're very good, we just adapt people's anatomy and function anatomy and circumstances and exercises to try and get the best of their function back. As far as costs go, we don't really know how much all of this costs in the UK, because we don't keep any figures, because we don't ask the questions. The only data that is well regarded is a 2010 study from Australia, where they looked at the cost of urinary incontinence, and they calculated it costs $43 billion a year. Because they didn't just include the cost of pads and surgeries and medication, which is what the hospitals are focused on. They looked at things like hip fractures. So if you are leaky and you're worried about wetting yourself and you hurry to go to the toilet and you don't have good balance and you fall, then you're at risk of getting a hip fracture. If you're over 85 when that happens, you've got a 25% chance of being dead within a year, which is expensive. So looking at people and what they are actually doing in their lives and how these issues impact on them, you can save an awful lot of money. The frequency of mental health problems from people that have had significant injuries and chronic illnesses is huge. Most of these people are traumatized and depressed afterwards. But we know that if you are also incontinent and you also have problems with your intimate relationships, then that is compounded by it. So if you talk about it, then you might be able to elevate somebody's mood just by removing one of their stresses.
And you've moved on to continence, which is a big part of what we're going to be talking about today as well. But just to add in a couple of things there from a critical care perspective, almost everyone in critical care who is sedated and or paralysed will be incontinent, and that is a fact. And yet, you mentioned about the catheter before in terms of opening that conversation, and I can count on one hand the number of times I've seen someone discharged who that has been a focus of a discharge plan. So if you have ongoing incontinence needs, and it's not just urinary incontinence, is it? It's anal incontinence as well. And I know this is a big thing of yours in terms of education. And so going back to the who should be asking, how should we be asking, who should be addressing these issues? Do you have any ideas around that? Because you've got some facts about how physiotherapy works for incontinence.
Yeah, there's multiple Cochrane reviews that say that conservative treatment for stress incontinence and the early stages of overactive bladder and prolapse management works. That just doing pelvic floor exercises regularly, so the study was 3 times a day for 3 to 4 months, had 70% of them got dry. Now that is cheap to do it. The cost of the intervention was €330. Like, it's so cheap to put in place. Where physios are very cheap, especially me. That there's lots that we can do. These aren't difficult things to teach. They're not complex in the basis of them. Like anything, it gets more and more complex the more that you look into things. But for the basis bread and butter of post having had a catheter and being debilitated and being constipated, that's not difficult information to put through, and there's lots of evidence to support it. It's just teaching the staff.
Thank you. So Kate, is that possible for the intensive care community? Everything Liz has said, everything Elaine's just mentioned, is this possible for us to educate our ICU clinicians to provide this advice, support and signpost and post-critical care discharge?
I think it is possible, and I think it's something that we just have to get on and do, and we have to kind of stop worrying about looking or feeling silly as we're saying things, or not knowing all the right answers or any of that stuff. I think we just have to get on and do it. And I do think it needs an MDT approach, because you're right, Elaine's absolutely right. My physio colleagues are going to be able to kind of give great advice on positionings and how to kind of cope with different muscle losses in different areas. And I think we have to be talking to our psychology colleagues as well about the elements of anxiety and depression, and how we can support patients with those elements, and how that affects libido, and how that affects intimacy, and how that affects intercourse. So I think it should be a round the table MDT discussion for every follow-up clinic for every patient, and everyone should be able to be kind of comfortable in having those conversations. I also think we need some guidance produced by our big central bodies to talk about sex, intimacy and incontinence after intensive care, and we just need to get on and do it. We just need to stop talking about it. We just have to get comfortable with it and start talking about it, and accept that there will be times where it feels a bit embarrassing and you might be a bit worried, but actually all the patients that I've spoken to about it have just been so pleased that somebody's asked them. I've got young male patients who've had pelvic fractures and who are now have got erectile dysfunction, and they're just too embarrassed to tell anyone, because they think, oh, I'll just go and buy some Viagra, it'll be all right, or whatever, and they just don't want to talk about it. But when you start to just kind of dig down about why they're feeling low and how things are affecting them, often it can be the thing that rises to the surface quite quickly in the conversation. So I think it is possible, and I think when planning rehab pathways for these patients post-intensive care and post-COVID, we need to be weaving this into it, because it's a core part of their future and their recovery. I think, for me anyway, I think it's just fundamental.
Absolutely. Elaine, you'll want to come in there?
As an add-on to that, the thing that has to be done carefully is being mindful that sex isn't always a positive thing in somebody's life. That people, if you start talking about it, you might be putting somebody into a situation that's very challenging for them. The stats on sexual assault and rape in the UK are really frightening. That 1 in 5 women have got a history of being sexually assaulted. So you have to be careful when you're raising these things with people, to be mindful that you might be uncovering something that they just don't want to talk about. Mm-hmm. And also about consent. If you're looking at somebody that's survived ITU and they've got cognitive changes, or if they've got side effects from medication or illnesses, then that needs to be factored into it as well. It can get quite complicated. Psychosexual counsellors are brilliant at this, but we don't have enough of them.
No, absolutely. I completely agree. And Liz, I am coming to you next. And one of the things I just want to fluff you up a bit with, actually, is I'm going to directly quote Elaine Miller here, Gusset Grippers, and saying sex isn't just about a penis going into a vagina. It is so much more, and it's not just always between a man and a woman. It's between women and women and men. And I want to just plant that seed with you, and how it's not just about penetration we're talking about here.
Not at all. And I think first you want to come back to it's you have to tell patients it's okay if they never want to have penetrative sex again. If they've lost their desire, that's okay. We don't want everyone to go swinging from the rooftops. I think from my field of breast cancer and with the menopause, it's all about libido, it's all about desire. And when you have no female hormones, or you've lost testosterone, you've lost muscle, you actually don't physically want to have sex, and you don't get turned on at things you used to get turned on by. And it's almost, you physically have to go through the motions to make your partner happy, but you don't get that same kick. And it's very hard to understand. And I think it just goes back to basics and realizing it's about touch and about being able to be open and honest and vulnerable with your partner, and your partner understanding that things may be very, very different. And I almost think the partners of anybody who's had major illness need to be talked to as well, because they will have frustrations and concerns, and they may want, look, you look normal, you're out, let's go and have penetrative sex again, and realizing how different it is. And I think a lot of breast cancer patients find it very hard to make their husbands understand, I love you, I find you attractive, nothing has changed, but I physically do not want to have sex because my hormones don't work. It is not me rejecting you. But by touching, by massage, we can be intimate and connect in different ways. And it is so hard to have those conversations. It's really, really hard. And to make everyone understand you're on the same field, it's, yeah.
It is. So Elaine, I'm going to come to you now, and also about some of the practicalities around everything Liz has just been saying there. It's not just as easy as.
Yeah, there is a graded program called Sensate Focus, SENSATE, which is valid. I don't know if it's validated actually, but it's the thing that is used to look at. So you would use visualization and you would use gentle touch and then grade it up to, if that's what you were looking for, penetrative sex. That is really, really good. And it's something that is used a lot for women that have pain in penetration or anxiety about penetration, and to try and, so I could go through what it is, but actually it's very good. It's available on the internet. As a resource to give to people that this is going to be difficult for you. Here's a bunch of stuff to try, see what happens, and if it doesn't work, then this is the referral pathway to try and get you more help.
Brilliant. Kate, I'm going to come into you there.
I wanted to ask Elaine, have you got any specific advice for helping patients with breathlessness and intimacy after intensive care? Because I think COVID is going to be a key, breathlessness and fatigue is a key issue for COVID, but it's also a key issue for all of our post-intensive care patients. And I just want to check that I'm saying the right thing. So I want you to give me your genius experience so I can try and add it into my clinics.
Yeah, my knowledge is pretty basic, so it would be making sure that they're taking if they're using an inhaler, that they take that in advance, that they're not trying to have sex after like a particularly heavy meal or lots of alcohol that's causing bloating, because that's going to increase breathlessness, that they are, if they have problems with phlegm, then trying to maybe not be frisky in the morning when it's really thick, that if they're trying to time it properly so that the phlegm's reduced, and do it later in the day. And positioning. So trying to look at different positions so that you're not prone lying, or you're using pillows and things to try and reduce the stress on your diaphragm. There's lots of creative ways that people come up with about using these like positional pillows that are foam based so that they're not collapsing under them. There's some very good straps and things that you can buy from adult shops that can help support limbs and reduce the cardiovascular load on sexual activity. And that can be really difficult for people, because then you're starting to introduce the idea of adult shops, which is not always something that people are interested in. There's a lot of crossover between the adult world and the medical world when you're looking at sex and sexual function, but there's a lot of cultural issues about trying to introduce this, and there's a lot of barriers to people. But when you look at the equipment, there's actually very little difference in, well, not in all of it, but there is a parallel. There's a couple of good resources of shops online that are run in a way that isn't your traditional adult shop. There's one that's run by a nurse called Jo Devine, and there's one called SH, it's SH with an exclamation mark, that's based in London. It's run by Women for Women, and both of those companies do a lot of outreach with the NHS and with clinics. Then they're nice, understanding people that aren't full of frightening gadgets where people just go, no. That if folk are looking for resources, these are good places to send them. But again, you've got to be careful with how you raise that with somebody, because there's lots and lots of people that the idea of an adult shop is just not acceptable.
Mm-hmm. No, I do have to agree with you there. Again, some of my patients that I normally look after in my everyday job is, chronic breathlessness patients, and positioning is key. And some of the information I've already referenced has diagrams and how you can do that. And for anyone that's worked with me, I'll never forget one of my consultant colleagues walking into a clinic as I had one of the clinic assistants bent over a table to try and demonstrate how that might be a position of comfort and ease, breathlessness and support, because you can fix your upper limbs in that particular sexual position. And I am by no means an expert. This is using physiology that we know, positions that would decrease breathlessness anyway, and how you can add in sex and intimacy into that. There's also, I remember there was many companies out there, like you said, but I'll never forget a patient coming to me and said they discovered Love Honey, and they get things delivered in a brown box with no identification of what it was. And some of the neurological symptoms we're seeing actually in terms of spasticity and neuropathic pain with COVID. This is where I would reference some of the amazing work from the MS Trust to look at vaginal spasticity and anal spasticity, and use some adjuncts, sex adjuncts, whether they will be vibrators or other instruments, if you like, that can help ease spasticity in a controlled way, so they have control over that rather than being during the act of penetration, like you said, Elaine. And you mentioned vaginal dryness as well, as Liz did, and I know you've got some experience of lubrication as well, and what is the right advice around that?
Yeah, I think we should just be slapping lube on everything all the time. It's really criminal that people don't know about lube. If I had my way in sex ed, young women would be given lube, a mirror and a map and told, go and find your bits. As a side effect of medication, as a side effect of being debilitated and aging and other illnesses, then women often have problems with vaginal lubrication. It's seen as a thing that's sort of shameful, that either your partner's not trying hard enough and you're not turned on enough, or it's that you are old and dried up and no longer sexually functioning. There's different types of lube. Water-based ones are great because they're pH neutral and they're not going to disrupt the vaginal flora, which is important actually, because a lot of people that are leaving ITU will have problems with thrush. And so that needs to be addressed. That would be another way in of asking people about their sexual function. If you ask them, have they got thrush and do they need treatment for that? That thrush obviously can make things very uncomfortable if you're having penetrative sex, and it's just really sore anyway. So anyway, lube that's pH neutral is not going to irritate the tissues that can be excoriated from having catheter. You can get oil-based lubricant as well, but it's not compatible with condoms. But it can be really good, especially amongst older women, if you put a layer of water-based lube in first and then oil-based lube on top, because water and oil don't mix, so it's super slidey, and it's you don't ask patients to do anything that you haven't tried yourself. Right? It's worth it. And you can get silicone-based lube as well, which is also very good, and it's longer lasting than the other two, but it's not compatible with adult toys that are silicone-based because it'll rot them, and that's not ideal if you've spent a lot of money on it. Some people want to use things that are more natural, like coconut oil and that sort of thing, which works as well. Some people are a bit more sensitive, their tissues can get a bit irritated, but if you don't have lube handy, you might have a jar of coconut oil in the kitchen that you could sprint for. Lube's available on prescription as well. There's a couple of different types. Yes is one, and Silk with a Y is another one that are available on prescription in the UK, which is another way of getting in, asking the question of the patient for GPs to say, is it a problem? Would this be of benefit for you? But yeah, even for people that are on their own, they should just, give it a shot. It's worth it.
Thanks, Liz. I'm going to come over to you now.
I was going to say I love the Yes lubricant base. There's no chemicals in them. People put all sorts of horrible things inside them, and I think you want it to be as natural as possible. You can get Yes on prescription, which is great for cancer patients because they do get free prescriptions, and it's oil and water-based, vaginal and anal, and they do internal vaginal moisturizers as well. The Silk is a silicone-based one, and I've tried it. It tends to smear everywhere and doesn't stay where it's put, but I wish everybody knew about this from in sex ed. It's so important. And also, if you do have a dry type vagina, you've got spasticity, you can use it with very small dilators just to help stretch things up. But it can be hard to introduce it, to tell your husband, I don't get wet anymore. It's not you, it's me. this can help and make them realise that lubricant is now a normal part of intimacy and foreplay.
Fabulous. Kate, do you have any comments on that?
No, but I just completely agree that we need to be talking about lube really early on and getting everyone comfortable with it. I was going to ask everyone and talk a little bit about stomas. So lots of our patients might have had bowel surgery and then be left with stomas and very drains and fistulas and bags. And I think there's a real challenge with how we help patients navigate the leakage issue, the smell issue, the how do I introduce this if I'm not in a relationship and I'm trying to start a new relationship. And I think we as a group have a duty of care to our patients to talk about this in the context of whatever issues they've got. And I think stomas is something that we need to be talking more about, and how we can support patients with bags and positions and draining. And I think smell is a key issue for a lot of my young patients when they're worried about being intimate with their loved ones. If their stoma makes a funny noise in the middle, will they think I'm, because I think fecal incontinence, like Elaine was saying, is so challenging. And I think sometimes people feel that because you've got a stoma and because your stoma is active, then you're being fecally incontinent during sex, which it clearly isn't, but it's a body process. But I also think it's about making sure patients are aware what they can do with their stoma and what they can't do with their stoma, and safety issues of, if people are trying to insert anything into a stoma, it's not the same as anal penetration, it's different. And if you've had kind of changes in your anal anatomy, I think it's just important to have those conversations with them nice and early, and get the surgeons involved if they want specialist advice.
So Liz, can I come to you first, please?
Yeah, I think so. I knew a young 30-year-old who'd had bowel cancer and had a stoma, and she went to a surgeon and said, what do I do on a one-night stand? And he was just gobsmacked. And I do wonder, if you can't, as a healthcare provider, imagine having sex with a stoma yourself, how are you ever going to talk to your patients about it? And I think it's a natural, disgust is the wrong word, but it's very hard to come to terms with you potentially having sex with stomas and fistulas and bags. And if you can't go there, then you can't help your patients. And that's where I think you need patients who have gone there, who have a stoma, who are having one-night stands, to tell us what they use, how they cope, what are the tips and tricks. And I think patients are the biggest way to drive change. You get a group of people who are happy to talk about everything and put them up there and say, you can do it. I know, I've learned the hard way. Let me tell you what works for me so you can pass that on to others. Because we don't know, we're not experts in this. I've never had a stoma. I would have no idea what to say, but I would find a patient who could tell me and I would pass that on.
Amazing. Elaine?
Yeah, I agree. I think we have been very poor at engaging with patient experts in all of these areas, where the crux of the matter is it's just embarrassing. When you hear patients' accounts of things that were brilliant in their care, that really, really helped them, and things that made them feel worse than they already were, then it's makes your practice much more informed. But again, it's quite hard to get hold of people, because once they are discharged, often they're gone for a long time. It's quite unusual. We're not good at keeping track of people to say, can you come back and educate us about what was beneficial? Yeah.
So, yeah, Kate, okay, this is where you might come in terms of the rehab legend work and also ICU steps and the patient experience. Kate, Liz, I think that is so powerful, talking about these issues we've been talking about is normal and naturally as we do about muscle dysfunction and fatigue.
I think you're absolutely right. So as you know, Rehab Legend, we have lots of patient stories, and I've been speaking to some patients about the fact I was doing this podcast and how could I make it better. And we all absolutely came up with the same thing, is that we need patients to tell us what works. We need to talk about one-night stands. We need to talk about lube. We need to talk about stomas. We need to talk about underwear. We need to talk about all of that stuff to be able to make sure it's better. And I think Rehab Legend, we have a capacity with our patient groups and with Rehab Legend and with all the other kind of expert via experience groups that we've got now in the kind of UK and all the different centres to really start talking about it. I think people are a bit anxious and a bit worried to talk about this kind of stuff. And I think we need a way of engaging them in a way that they feel completely safe. But I think what's useful about sharing patient stories on social media is that we can get some of that stuff to the people who really need it, and that it doesn't become something that only one centre is great at, that everyone is talking to everyone about it. But I think patient stories are fundamental to make sure we get this right, which is why I started Rehab Legend, because I just wanted to share all the amazing stuff that's going across the UK with everybody so everyone can get better.
Liz, can I come to you?
As a patient who has spoken about her sex life in the Mail on Sunday, I was terrified about sharing it. And there's one thing writing hypothetically about patients you've learned things from, but when you are exposing intimate details about yourself, it's really, really, really hard. And I think you need a really warm, welcoming space so patients can feel it's normal. And you just get one person to start and then someone else will come and someone else can come. But it's a huge thing to lay bare your lack of intimacy, your vaginal dryness. It's really, really hard. And it's just finding those couple of people who say, yeah, I don't mind. I'll go out there because I'll help other people.
No, definitely. And I think maybe, Kate, that's a task for you and I to help inspire our colleagues and professionals. But just to try and wrap some of this up and then give everyone an opportunity to speak and kind of summarize. So the purpose of doing this particular podcast was the forgotten or the unspoken about hidden problems that people may encounter after intensive care admission, and particularly after COVID-19, because we're seeing more patients with the same disease phenotype, if you like, and we're predicting they're going to have these problems as every post-intensive care patient may have. So in the acute sense, just clinicians start to think about things that we've talked about. If they've had a catheter, if they've had ongoing continence problems, that just won't magically get better. They will need to be signposted. So tell them this is normal. This may be normal after an intensive care admission. It may be normal to have ongoing continence issues. It may be normal to have vaginal dryness. It may be normal to have changes in your sexual appetite, desire, and intimacy. And it's normal. So please just speak to someone about that. Now, in your area, you might have a really good relationship with your GP. You might have a good relationship with your respiratory clinician if you're already under one, or your specialist nurse, or if you're fortunate enough to have a post-ICU rehab clinic that you go into, you could mention it there. So the clinicians out there, none of us are sex experts on this podcast by any means, but some of us have lived experiences, some of us have patient experiences, and we know it is a real issue and we want to make it better. So by doing this podcast, it might kind of open up some ideas in your own mind, or some of your own insecurities, or your lack of confidence, or maybe your need, like Liz says, to go and find out what's available in your own hospital. There may be things that exist already where you can signpost your patients to and get help, or online resources. And then finally, I think the so what factor is really important for me, because we are moving away from survivorship in healthcare to what matters to you, what matters to me, what matters to families, and one size doesn't fit all. And we need to be mindful of that, and how we really, because we do care, we're all in healthcare because we care, and we need to start looking at those boundaries that exist and how we can change and how we can educate and how we can understand. And definitely, Kate, using the patient stories is huge, and I think that's something we can start to do offline. So Liz, if I can come to you first with some final thoughts, comments, and what advice you have for our community of clinicians.
I would love every healthcare provider looking after a patient to talk about sex and intimacy. And it's embarrassing, but we do embarrassing things all the time to patients. We put fingers and tubes in orifices, we do intimate examinations. And if we can make it part of our normal practice, you could say, right, as part of my normal review, I ask everyone about their sex, intimacy, and continence. It's normal. How are you? It becomes part of your normal pattern, and the patient just thinks it's part of the normal exam. I think we have to be the ones to normalize it and just do it all the time and tell them, I always ask about this. If it's not the right time, that's fine. That's what I would say.
And for those clinicians out there who may be just really embarrassed to start, what advice do you have?
I think you work with a team. So I realized I had no idea what my breast care nurse has said to my patients, because I was always talking to the next patient. If your patients are seen as part of a team, make sure someone in that team is talking about sex. It may not be you. For religious, cultural, you don't like the patient, it's not the right thing, but make sure someone in that MDT has had that sex discussion. And for them, it'll be a normal, this is what I always ask. If it's not the right time, we can come back. But you can't assume that somebody's doing it. because nobody will be.
I absolutely love that, and that is so powerful, an amazing thing to kind of summarize. Thank you so much. Elaine, moving over to you.
Yeah, I think that similarly we need to get better at just asking about continence. The chronic cough that's associated with COVID, even for people that haven't been so seriously ill that they've been admitted, is going to land up having significant ongoing problems for a lot of women. It was seen in the Australian bushfires when the air quality was so poor that women were coughing, and there was a huge spike in people referring with stress incontinence. I'd really like to see that being flagged up as, is it a problem? Here are the simple things that you can do to try and help.
Fabulous, thank you so much. And as well, Elaine, you, like Liz, have so many online resources, so I'm sure we can share some of them underneath the podcast as well, in terms of how you can do that in your own unique manner. So Kate, moving on to Kate.
The only thing I would say is that don't be ageist. Don't think just because they're of a certain age that they're not having sex. So I have fallen foul of that before and thought, oh, well, they're in their 80s and they had the best sex life I've, ever heard of. So I think don't be ageist, ask the questions and just make it part of every conversation. And I think whenever I'm having a conversation with a patient about it, I channel my inner Liz. I listen to Liz's Pleasure podcast and I just channel Liz. So listen to her podcast too and channel your inner Liz every time you're talking to a patient.
Great. Inner Liz and inner Elaine now. Absolutely. So I just want to finish by saying thank you very much, everyone. It's been an absolute pleasure. And if you are an organizer of a medical conference, if you are an editor of a journal, if you are a clinical director, if you're a consultant in charge of a multidisciplinary team, just please have a think about what we've said. I'm sure we're all available to contact if someone is really struggling, or if they do want to be signposted, but let's get the conversation started. Let's get the ball moving together, and we do have to look at different specialities to do that, which is okay. So thanks so much again. Thanks for your time. Really appreciate it.